Well, welcome everyone, and thank you for joining us today for the second inHeart webinar of 2025 and the 10th webinar in the series. Today we are discussing disrupting convention, new RCT data on VT ablation guidance strategies. We had over 100 people register for today's event, so we're very excited to kick it off. We're joined today, or we will be hearing presentations by Dr. Hubert Cochet, Dr. Pierre J., and Dr. Fred Sacher, who are all joining us from Bordeaux University Hospital. In addition, we have an esteemed guest panelists, Dr. Andre Davile and Dr. Tim Maher from Beth Israel Deaconess Medical Center, and Dr. Jeff Winterfield from the Medical Center of South Carolina. My name is Katie Arnold, and I will be moderating today's conversation along with my colleague, Kristen Lomas. We will be recording today's discussion for use online and to share with further colleagues of yours. So your continued attendance on this call will serve as consent to the audio and video recording and its distribution. Our format for today will include 3 presentations followed by Q&A. Attendees, we encourage you to submit your questions via the Q&A feature at the bottom of the screen, and we will work your conversations into the conversation at the end. We have lots of content to cover, so let's get started. Dr. J, we will start with your presentation.
Thank you very much. Appreciate to be here. I hope you see my screen.
Yes, it is great.
Perfect. So I'm in charge to do the introduction for today's webinar, and it all started in 2010. So that's 15 years ago. And it started with an academic effort, mainly Hubert and myself. We made a project that was founded, and we got some equipment, and also we started building with the help of Maxime Sermezan. We started building some of the bricks that inEurHeart is using today, and then inEurHeart was incorporated in 2017. So 7 years after we got started with this academic effort. And the aim was really to provide the EP doctors in the lab with all the information that we knew were present in those images of the heart of our patients that we image anyway before ablation for most of us, and export them in models form to navigation systems. There's a lot that can be done conventionally. I have a lot of admiration for all this work by pioneers where with PPI you can in fact understand a lot, and you can identify the VT channel really with the entrance, the exit, and some bystander loops, etc. But it's not always very convenient to work like that. And there are plenty of limitations with what we call with what we call conventional strategy. And that includes the 3D maps, in fact. So I listed some of them here. You know that very well. And so there has been some efforts to be able to work in sinus rhythm. And one of the most remarkable efforts, I think, comes from Frank Marcinski. That's even earlier. We're talking about 2000, where with the very early versions of the Cardiology system, this group made some voltage map and then transected the scar with RF deliveries. And that was the beginning of, kind of anatomically guided ablation, because it was used also in patients in whom you can't induce the arrhythmia or when it's poorly tolerated. And we also developed some strategy here where we were looking at specific potentials that we call LAVA. And these are surviving electrical activities from surviving bundles in the scar. And those bundles are very poorly coupled with the rest of the myocardium. And then came the idea of could we identify those bundles in the scar. And in these early days, we're talking about 2012 here, really the imaging modality that was mostly used was MRI, and particularly late guide enhancement, which suffers several limitations, but is giving some nice contrast image of the scar. So you can really use that to reconstruct the heart in 3 dimensions, because this is not very useful to plan an ablation strategy. You have to memorize where the scars are. It's not very easy to use. So having this kind of model is so much better. Plus, you can export that to your navigation system and then see your catheter in the same coordinates with respect to the anatomy and to the scar, to the substrate. So it's advantageous. And then you can also identify some channels of surviving muscle in the scar. So all of this is based on MRI. And then we started to look also at CT scan, because CT scan has the advantage of being very reproducible from one center to the next. It's always the same calibration because it's calibrated on water, and it has a fantastic spatial resolution that is way better than what MRI can do. So we started to look at CT scan as well. And we even did some MR CT fusion. That's very interesting because you have the benefit of having the very detailed description from the CT scan and the substrate from the MRI. But we thought that we could, in fact, welcome any type of imaging and really make the model of the patient's heart and export that to the CARTO system. So here, for example, or CARTO or NAVIX or Rhythmia, and now Prism for Affera, Medtronic, etc., etc. It is compatible with everyone. So this is an example of a IRVC case that we did years ago. It's an old slide, by the way. And it shows you the substrate. This dashed green thing is the substrate as per the MRI. That's fatty infiltration. And this red thing here is where the exit of the arrhythmia was localized. By the way, using the VEST with the ECGI system. But really, we wanted to have a platform that is super flexible when it comes to the input, and then that is compatible with whatever navigation system you can consider. And then we further looked at the CT scan. And it all started by, making some assessments on how the wall thickness was predictive of the low voltage. In fact, a myocardial infarction scar results in a very important thinning of the wall. And this matches pretty well the voltage map from our systems. It also matches pretty well where the LAVA potentials, those potentials that are poorly coupled with the rest of the myocardium, are recorded. And interestingly enough, the most delayed LAVA, so this is the delay after the end of the QRS, so it's super late. The latest LAVA were really recorded in the thinnest part of the scar, which is probably a part that is going to act as a barrier, as a boundary for the channel of the VT. And we know that because there has been some work showing that the most delayed potentials are not those that we should target. it has been demonstrated afterwards, particularly Rod Tung did some wonderful work on that aspect. And so we came out with the idea that probably the VT channel, the VT isthmus, would more likely be in a relatively preserved wall thickness area in the scar. And this is one of the first CT channel that we identified. And when you look at this, so this is showing you in brown here on the right, the area that is less than 3 millimeters. And so in gray is more than 3 millimeters. And we had in this patient a nice VT circuit, was in fact 2 isthmuses during the VT. And this, in fact, matched very well these 2 isthmuses of relatively preserved wall thickness. And so from this observation, we thought maybe there is an ablation strategy here. Maybe, in fact, we have everything we need in the images, even before we get to the lab, to identify the targets. And so this is shown here better with more recent images, but it's the same concept. This is showing you the voltage map. It's an ischemic patient. This is the voltage map. This is the wall thinning. And again, there is a very clear channel here in between 2 barriers or 2 areas of reduced wall thickness. And if you look at the MRI, it is showing a much bigger scar. And in fact, after accumulating cases, we came to the conclusion that, in fact, unlike what we thought initially, the CT scan based on wall thickness would be superior to identify targets in post-MI VT patients as compared to MRI, where we have a bigger scar, which is true, no question, but the area that may serve as a channel is better described by the CT scan, as surprising as it may sound. And then we have plenty of demonstrations where, in fact, we had a very good match between the mapped VT, when it was possible to map it, and the CT channel. Again, this CT channel is the area of relatively preserved wall thickness in the scar. The dark red is less than 1 millimeter, and it goes all the way up to the light yellow, that is 5 millimeters. So it turned out to be pretty powerful, and we started to use it even in very complex cases like this one, where the scar is huge, very heterogeneous, and yet it predicts pretty well where the channels are. So it's very advantageous, and you will see more how we use this. But really, the concept is that you can identify areas that are going to be acting as barriers during the VT, and you can, in between, have those channels that we identified in green here, and you can target the most vulnerable part of the channels, the CT channels. And this is where you have the thinnest area of the channel. So, for example, here you could ablate here, and it would work acutely, but the risk for reconnection is very high. Same here. But if you ablate here, it's way more vulnerable because the wall thickness is so much less that the likelihood for a durable lesion is much higher. And so this is what we're doing now. This is our ablation strategy. It is all planned before ablation. And I thank you, and I stop here.
All right, thank you, Dr. Jaïs. We are now going to have Hubert, Cochet. Oh, I'm sorry, no, Dr. Fred.
Fred, yeah.
Yes, thank you.
Yeah.
Sacher.
Thank you.
Thank you.
Thank you very much. And thank you for the invitation. So I will present you the results of the inEurHeart project. Oh, what happened to my? Can you see?
Yes, we can.
Okay, good. So I will present you the results of the inEurHeart project, which was presented as lead-breaking trial during last HRS. So basically, the idea of this trial, which was an institutional trial funded by the EIT Health, it's a department from the European Commission, and the idea of this this randomized control trial was to test what Pierre just showed, and actually ablation, VT ablation based on these channels or anatomical channels as identified by CT or CT guidance arm versus the standard or conventional arm, which is basically what you are usually doing, but without imaging. And the main objective was to compare both of these approach in terms of VT ablation, in terms of procedure duration, efficacy, safety, and cost. So we included 113 patients in 4 European countries, 14 clinical sites in Germany, Switzerland, Austria, and France. And on these 14 clinical sites, what is important to note is on 11 did not have this CT guidance strategy as a standard workflow. And this was made on purpose to see, because one of the points here is to try to simplify the procedure and to make it easier, especially and even in patients with less experience in VT ablation. So we wanted to see whether it could be generalized even in centers with less experience with this strategy. So the criteria were quite standard for VT ablation in ischemic cardiomyopathy patients, so that to get de novo VT ablation prior myocardial infarction, and a kind of VT, a certain number of VT episode, and it was exactly the same criteria as in the VANISH 2 trial. Exclusion criteria were quite standard also. Intracardiac thrombus, of course, any secondary causes that could be treated. And the only thing was creatinine clearance below 30 milliliter per minute, which was a contraindication because for all of the patient, we needed a CT scan and injected CT scan with contrast. So the way it worked, the trial work is everyone had CT scan with contrast injection to rule out intracardiac thrombus, and then CT scan raw images of the CT scan were imported on a web-based platform. And then for those randomized in the CT guided group, the images and this wall thickness map were downloaded, and the center could get these images, and then these images were imported in the 3D mapping system. So there was a core lab to review those maps, and we can discuss that later to identify potential isthmuses. So once you get these images in the CT guided group, you merge them, and it was a very important timing. Basically, we merge using, if we go transeptal, using pulmonary artery bifurcation and coronary sinus, and then we adjust with LV apex and anterior, inferior, lateral, and septal part. And then if you go, when we went retrograde aortic, it was with aortic arch. So, but this merging part was, of course, crucial, because if the merge was not good, then the rest of the procedure may have been impaired. Then once the merge was done, we did not need a full substrate map, because we have it. We have an image substrate map, and we navigated in targeting those isthmus that Pierre just showed you. And the goal was to render the area non-capturable. So we already connected very thin area between each other. And then we paced inside to make sure we could not capture anymore this area as a local endpoint to go for the second place and etc. Then once all these identified anatomical isthmus were treated, we did EP study, and if it was negative, we stopped there. If we could induce monomorphic VT, we go further to ablate them by mapping, activation mapping or pace mapping. But it was possible. Any mapping strategy was possible. So we at the end we had 57 patients in the control group and in the CT guided group. One was not excluded, but one did not go to the procedure. He had a problem before the procedure, so he never had any ablation. And so we ended up with in a modified intention to treat 56 patients in the control group and 57 in the experimental group. We had the per protocol population analysis also, and you see that we lost 8 patients in the CT guided group. And once again, this was probably one of the reasons was probably that the workflow was not standard in some centers. And actually, in those were excluded or not excluded, but those were not in the protocol because the all map has been done of the substrate, which was not allowed in the CT guided group. We had to rely on the CT substrate. So here are our population: 56 patients in the conventional group, 57 in the CT guided group. You see that mean age is pretty standard. It was pretty long after myocardial infarction, almost more than 12 years after. The LVEF was pretty standard, the same EF that was found in other VT ablation trial, randomized control trial, 35%. History of electrical stump was pretty high, actually. 40% of the patients had an history of electrical stump, so probably referred slightly late in the course of their disease. And the first difference in terms of procedural characteristic is the use of identity mapping, and that was on purpose because in the CT guided group you didn't have to actually use identity mapping because you would rely just on the CT images, but it was still used in 14 patients, 25% of the patient. And but in more than 90% in the conventional group, which was expected actually, because this is you need identity mapping to get a substrate map, and also for if you wanted to do activation mapping for VT. More than 90% of contact force catheter, but it's not 100, and it was required in the protocol, but even though almost only 90% in both groups get contact force catheter. And more interestingly, when we tested inducibility after CT ablation, 3/4 of these patients were rendered non-inducible after ablation. So it was we stopped with the CT ablation in just with CT ablation in 3/4 of the patient. When we look at those in whom we induce VT afterwards, there was 2 different type of patient having VT that were actually coming from an area which was already targeted, but we were probably not transmural and did not have enough long it recovered after application. So it was a problem of ablation. And in other, it was other area, and mainly in fast VT, a critical part of the circuit being in the border zone, and probably, and we can discuss that further, but we may not have enough spatial resolution to identify isthmus of very fast VT, or at least those in border zone when you have less wall thickness heterogeneity. And finally, in terms of procedural complication, there was no difference in the two groups. Looking at the primary endpoint, which was the procedural duration, it was defined as the time between the first catheter introduction to lateral application. We had a decrease of by 19.1% in the CT-guided group, and it was significant in intention to treat, but also in per protocol, we had a decrease of 30%. So when you really look at the protocol, you reduce the time of procedure by 30% when doing a CT-guided ablation. Looking at recurrence, because it's important, it's great to get easy and quick, but you have to be effective and sure. So we've seen on safety there was no difference. And what about efficacy? Actually, in the intention to treat, we had with 76.8% of efficacy at 1 year in the CT-guided group, so an increase of 9.5% in efficacy, but this was not significant. The study was not powered for that. And in terms of patient, if we just look at patient with contact force catheter, we increase 14%, but still not significant. What was highly significant is the reduction of VT events in both groups, reduced by 90%. The VT burden 6 months before, 6 months after ablation was reduced by 90% in the CT-guided group, by 30% in the conventional group. But because of one patient, we had a lot of recurrence afterwards. So the reduction was significant, but the difference between conventional and CT-guided was not. We look also on unplanned cardiovascular hospitalization, cardiovascular deaths, and VT events. So still a trend with a difference of 11% in favoring CT-guided arm, but not significant. And finally, the cost of the procedure. So it's quicker, easier, as effective, not with the same safety, and we identify a decrease of cost by 10% using CT-guided, and that was for two reasons mainly: the limited use of high density mapping, catheter, and also the reduced time of the procedure. So to conclude, the digital twin of the infarct scar based on the cardiac CT scan to guide VT ablation allows a reduction of procedure duration by 19%, 28% when the protocol was followed, without increased procedural risk, with a 1 year VT-free rate of 76.8% versus 67.3% in the commercial group, which was not significant, and the procedural cost reduced by 10% in the CT-guided group. Thank you very much.
All right, excellent. Thank you, Dr. Sacher. We will conclude now with Dr. Cochet, who's going to be talking about where we are going in future trends before we open it up to the panelists to have discussion and Q&A.
Thank you, Katie. I will try to share my screen. Do you see my screen?
Yes, we do. Great.
Great. Okay. Hi, everyone. So
actually, there it is. Thank you.
Okay. So I was asked to talk about the future directions. In fact, what Fred just presented is only half of the inEurHeart project. The inEurHeart project that was funded by EIT Health, led by Maxime Sermezan, a computer scientist, was half dedicated, the budget was half dedicated to conducting an RCT and half dedicated to develop technology, partly based on the data collected during the RCT. And this gives us a good opportunity to review what may come next. So this is the plan that I will follow. There are avenues of progress in the field of acquisition technique. Imaging is progressing, both CT and MR. In the field of enriching these models with physiological data to perform computer simulations. In the field also of combining this substrate-based analysis, non-invasive image-based substrate analysis with innovations in catheter ablation. And also, we will briefly talk about risk stratification applications of these technology. So with respect to imaging, starting with CT, CT is progressing very fast thanks to the advent of novel detector technology. So this is now available in routine clinical practice for 2 years now with one vendor. It's called photon counting CT. And these detectors change the game because they enable a direct conversion from X-rays to electrical signals, thanks to a semiconductor that is directly directing each incident photons directly to a pixelated anode. And this allows to detect each photon separately with a much higher spatial resolution, but also to measure its energy and to be able to reconstruct different images depending on photon energy. So this leads to improved contrast, much improved spatial resolution, improved tissue characterization thanks to this multi-contrast strategy, and also dose savings because these detectors are more sensitive. And this allows us to progress in the field of tissue characterization in the myocardium, performing late iodine enhancement with CT with a quality that is approaching what can be done on MR. In the prior generation of CT systems, there were still issues with the noise in these images that prevented us from really discriminating channels of gray zone within scar or subtle scars within myocardium. And one strength of this technique is also that we can compute the extracellular volume, meaning that what we see is not only a contrast, but an absolute value that we can reconcile with histological data. So we know that a dense scar is an extracellular volume greater than 70%. So 70% of the pixel is not myocytes, and gray zone is probably between 35 and 70%. And so we have one of these systems in Bordeaux, and we've been comparing the late iodine enhancement technique with CT using the prior generation of CTs. So what you see here is CNR, so contrast to noise ratio. So it's our ability to discriminate between the scar and the normal myocardium using the prior generation of CTs, which were already very advanced CTs. It was a Siemens Force system. And this is the contrast to noise ratio with the new CT technology. And as a comparator, this is the gold standard, the MRI gold standard, which is still higher, but we see that we are approaching that. And what's important is to look at the spatial resolution, because this MRI gold standard, it's not high-res MRI, it's low-res MRI that can achieve this kind of contrast. And with late iodine enhanced CT, we have a much higher spatial resolution to detect subtle channels. In the field of MRI, there's been some progress, and we've been working in the lab also to make the field advance a bit towards a better detection of VT substrate. So the current gold standard in MRI is called PSIR. So it's a method that has a great contrast between the myocardium and the scar, but a very poor contrast between the scar and the myocardium. And the contrast is still a bit relative. So what we've been doing is developing a sequence that acquires simultaneously two contrasts. One is totally black blood, so we see only the scar, and the other is bright blood, so we can segment automatically the myocardium. And we can obviously fuse these two images, and this allows us to detect more scars, especially in areas where scar is non-transmural in contact with the blood pool. And this also allows us to automate the extraction of scar. This was still a limitation using MRI. It was much more amenable to CT, the fully automated substrate analysis. With MR, it remained a challenge. Now we are able to leverage on this bright blood image to automate the segmentation of the myocardium, and then we can extract scar characteristics from the black blood image. So these are progresses in imaging technologies. And now what we can also do, and that what we've been exploring as part of inEurHeart, is to introduce some physiology in these models. So for now, the definition of channels from imaging relies on imaging feature, morphological features. So on MRI, it's channels of gray zone within dense scar, and on CT, channels of relatively preserved thickness within severely thinned scar. And what we can do is use this scar intensity or wall thickness as a parameter to parameterize, to personalize a model, a cardiac model of electrophysiology. And then we can paste the model and try to induce arrhythmias. So we've been working on that, and particularly using CT, because CT, again, is amenable to fully automated processing. So what I show here is an automated VT simulator. You just input the image, and all the rest, the segmentation, the extraction of tissue features, and the simulation of VTs is automated. You just get the results in the form of VT circuits and inducibility rates. So it starts with a segmentation of the whole heart and discrimination of the tissue with respect to its wall thickness, presence of fat and calcification. And then the model can be paced. So here it's paced anteriorly. Let's come back here. Yeah, here it's paced anteriorly here. And then some scars will be heterogeneous enough to be able to support re-entry. So this is a re-entry, and now the VT is turning. And the strength of these models is that we can do what we cannot do in patients. So we can try to induce VTs from hundreds of sites. So our current strategy is to, over 2 or 3 hours of computing, we're not working, the computer is working. We try to induce VT from 100 sites. So in the end, we get 2 results. First, an inducibility score. So for instance, in this model, 47 sites were able to induce VTs. And then we are computing simplified surface EKGs to recognize VT circuit and to group these. And in this patient, these 47 inducible VTs were in fact 3 circuits. So we can get these 3 circuits. And we are now validating this and using particularly the control group of inEurHeart, in whom we had VTs that were mapped, to validate this strategy. So what you see on the left is a map, an activation map during VT, and this is probably the simulation that matched the best this circuit. This is another case where we had 4 circuits that were inducible in silico, and this one was probably the one that matched the clinical one. And inEurHeart, as part of the inEurHeart trial, has developed a prototype that could be made available to its clients as part of research. Obviously, it's not a product that allows to pace the myocardium from any pre-computed sites in order to visualize if a VT was inducible. The third part is combining image guidance with large footprint catheters. So we all know that the ideal VT catheter is different from the ideal AFib catheter. We've been working at Lyric on the Sphere 9 catheter. This is an experiment in an animal on photon counting CT. We see that the lesions are very, very deep. And these images are from the Eladonter paper, showing that these lesions induced by PFA were deeper, larger, and more likely to be transmural. And interestingly, this could be preserved also in very heterogeneous scar tissue. And we think that this type of catheter design would be ideal to allow for single-shot ablation on these CT channels, because these CT channels they can be 5 to 6 centimeters long, but they are usually less than 1 centimeter wide. So performing focal ablation on each of these critical sites as identified preoperatively could make the ablation of slow monomorphic VT after myocardial infarction as simple as PVI for AFib. And the last part is risk stratification. This is probably a bit further away, particularly in ischemic heart disease. inEurHeart was focused on ischemic heart disease. For now, what we know is that when we are quantifying the scar, we can discriminate between dense scar, which is not arrhythmogenic, and gray zone, which is arrhythmogenic. It's a bit complicated because the reproducibility of these thresholds are not perfect. But when we have nice images and a large cohort, this was the largest paper on the topic, the results from this scar analysis clearly outperformed LVEF for primary prevention of ventricular arrhythmias. What we were willing to introduce within inEurHeart is a different approach that is not only based on a quantification of the scar, but on its heterogeneity and spatial distribution. We can do that using AI. So we've been training a model to identify wall thickness maps on bullseye maps that were associated with ventricular arrhythmias. And in the end, we came out with a model that was better predictive of ventricular tachycardia than LVEF. And the other approach would be simulation. It's maybe useful to guide VT ablation, but probably the in silico inducibility may be an indicator of the stability of the scar and its propensity to show arrhythmia. So I thank you for your attention, and I show the plan again if you have any question on this or that topic.
Well, thank you from all of our presenters at Bordeaux. We're going to now open it up to our esteemed panelists to provide their thoughts, their comments, and I will alert you there are some questions in the Q&A. You can feel free to integrate those as you see with the discussion. So looking forward to hearing from you.
Do you want to wait for questions, or you want us
No,
to?
we would love, Dr. Davle, you to, please provide your thoughts on what you have just listened to, Dr. Maher and Dr. Winterfield.
Great. Congratulations on all of this great work in a great project. It's not easy doing a large randomized controlled trial, so that's wonderful. I do have a few questions about the trial. In terms of the data, you showed that their procedures were shorter with the CT guidance, but the ablation time was longer. So you've traded some mapping for ablating. But was the ablated area larger? Is it picking up sites or isthmuses that traditional mapping and substrate ablation approaches are not? What is the sense that you guys did? Are you ablating larger or broader areas than a traditional substrate ablation approach?
I can take this one. Yeah, so thank you for this question. This is effectively an important point. So yeah, this could have been, the thing is, we mainly, as we try to connect two areas of wall thinning, these areas were particularly ablated with 50 watts with at least 10 grams for 45 seconds to 1 minute at each single spot. And so we really go for dense ablation until the area is non-capturable anymore. So it can have led to several lesions at the same area to render, or around the same area to render it non-capturable. Whereas in the conventional group, so it was led to the appreciation of the operator, but of the electrophysiologist. But some may not have done a full complete substrate map, even though it was required to go until non-inducibility in both arms. But the main reason, I think, was we particularly spend time to render this area non-capturable.
If I may, Fred, this is a very important point. Our intention was, in fact, to do exactly what you said, Tim, which is, take advantage of the images and use those as a surrogate for mapping and save time during the ablation and focus more on the ablation itself. And we know from before this randomized controlled trial that, in fact, CT channels are typically more than the VT isthmuses that you may identify during a conventional procedure. And it's not rare that you have 4 CT channels and only 2 VT isthmuses that are demonstrated. So it is to be expected that it's a larger ablation, but I suspect that because in the past we have had some evidence that the outcome was superior to conventional approach using image-guided ablation. And I suspect that this is also because we target more potential areas that may give some VT circuits, and not necessarily at the time of the ablation. Perhaps it requires further maturation, but in the time course, if you follow those patients for years, then you start to see a very significant difference. So I suspect it's also because of this more comprehensive, approach of the scar.
Yeah, and maybe to follow up on that, one of the things is we are still limited with RF or at least a small tip RF catheter in the ventricle, and having large tip catheter with RF or PFA would probably change that and it seems like a very good combo.
We have, right, team, I think we have the same impression too, Pierre, because when we use it in heart for most of our cases, as you know, but we still map, and we map with different wavefronts, trying to understand the substrate in a way that a modification of the substrate will be performed without the need for induction, which is essential for what you are trying to say, right? To make a VT a simpler procedure, and that's why we have the same-day discharge program here, which adds everything. So you add image, you have a quick map, and potentially an induction. But as you said, in many cases, there is a significant overlap between your channels and the EP channels, if I can call them that way. But because we see more when we have the scar, we typically we burn other channels that during the map were not exactly like seeming to be important channels for that specific substrate. But if the image is there, and in many patients, the registration is pretty good because we use ICE and everything, so the registration is good, we tend to expand the lesion set a little bit. Having said that, we are still far away from the old concept of homogenizing the entire red area. Yeah. So even when you combine EP channels to anatomical channels, you are still not performing as many ablations as you would have to do if you were just shooting for red dots, right?
Yeah, absolutely. That's a very important comment, Andre. Thank you for your feedback. Yeah.
We're jumping over sort of functional mapping though, and it obviates the need, at least with this approach, for the high density substrate guided, functional substrate guided mapping that we commonly do, Andre, right? With different wavefronts, waddles in your case, or decel zones and lines of block in our case, depending on which mapping system we're using, of course. This is mapping system agnostic, and which is one of the beauties of it. It does, one of the questions that emerges though is this model works very well for lateral boundaries, and thinking about VT and sort of the surface of 2 dimensions. But with 3-dimensional depth boundaries, how do we begin to identify those potential circuits that are less obvious from if there's not an obvious channel, as may happen, say, if there's just a dense kind of core of scar and almost like an island with sort of a fall off of wall thickness. That becomes a bit more challenging.
I agree, Jeffrey. And in my opinion, I see that same concept a lot in the type of scar that you're describing. And it seems that our lines of block or functional lines of block are often at the sudden changes in wall thickness. So it's not an isthmus of wall thickness, but is the interface from healthy to very, very thin. So I completely agree with what you're saying.
Yeah, I think that it would be very compelling to do a study with the large footprint catheters. I think it'd be easier to do it in Europe right now. We have compassionate use of these tools here in the US, but it would be hard to do a study with that when it's not even approved, for our use right now in the US. So we're a step behind, unfortunately, but it would be the idea of reducing the amount of time and kind of pulling back on our love of mapping. I think, the irony to me is that you created this workflow because you love mapping so much, Pierre, right? That was the lava paper in 2012 is still a paper that guides a lot of our decision making in the EP laboratory.
Thank you. Yeah, these are nice comments in there. Help us convincing Medtronic or Boston Scientific to have this study.
Talk
starting
offline.
now
Happy
in
to do
Europe.
that. I've been thinking
I
about this.
love that.
Yeah, let's keep talking.
Yeah, I think that one of the reasons, Fred, for you to have more ablation in a shorter procedure is also because when you image them, it helps you organize the workflow from the beginning. You plan the procedure better. And even if it's a critical situation where the patient is sick, you're going to try to focus in areas that you're more likely to see. In our case, that we map a lot, so you're going to try to focus in areas that look more important by image. So that's why you may actually reconcile the paradox of a shorter procedure with a longer ablation time, because the procedure flows a little bit better when you have all the image information prior to the beginning of the case. Can I ask you a question? If I got it right, you said that there was the personal cost of the procedure is less when you image. What do you mean by that? When you show like how you save money.
Yeah, so because of there are two ways. There are two components. Is procedure time, because you use the lab for less time, so less time of personnel and paramedics and nurse and physician, but also less use of high-density mapping catheter actually in the CT-guided group. So these were the two components of this reduce of cost. In this study, we'll have a full health economic study ongoing. In a dedicated work, looking also at the outcome and resources used after the ablation and during the following year. But this was just what we reported there is just the procedural cost, which was reduced by 10%. At least for the patient done in France, because it may also vary from one country to the others, depending on how much you are paid and how much cost the catheters, of course.
Sure.
Does that include the cost of the CT for the patient?
Yeah. Yeah, well, actually, the cost of the CT is the same in both arms because everyone got the CT, because once again, this is part of the routine, and it was even in the last clinical statement of pre-imaging. We use that for any VT ablation to rule out thrombus, making sure there's no too much atherosclerosis on the aortic arch. So even if you are not using CT guided, you will have a CT scan to rule out thrombus. So CT scan was not discriminating in between in both in the different arms because it was performed in both arms.
Guys, there are two questions from the chat from Sana Walni in Tunisia. And as time is flying, I'd like to be sure that we answer those questions. And the panelists, feel free to give your opinion because these are interesting questions. So Dr. Walni is wondering if this CT-guided VT ablation could prevent ICD implantation. And that's, an interesting concept. And so we're not there yet for sure, but I'd like to have your comments. And then her second question is even probably looking deeper into the future, because she's asking whether this type of image-guided ablation could reduce the risk of certain cardiac death. So it's kind of linked. So primary prevention, basically. It's kind of the same question somewhere, but I'd like to hear your thoughts.
Like version 2.0 of Smash VT, just within guidance. It seems reasonable to consider this as a prophylactic approach to reduce the burden of VT, but I don't agree with the idea deferral of ICD implantation with ablation. I know Rod's data is very compelling from China, but the guidelines just aren't there, and at least in the US, it would not be standard of care.
Yeah.
Would you have the same answer for someone with 50% ejection fraction, for example?
That's different. Yeah, I think that's where it'd be reasonable to consider it, I suppose. It's debatable. It's why we have shared decision making, I guess, is how we
Yeah.
notes.
Yeah.
It's not primary prevention. And now we're talking about a population that would be much more complicated to ablate, because if you position yourself in the period where primary prevention is the question, you're not 15 years after the MI, as we were in this study. You're 3 months after the MI. So there's no severe wall thinning at this stage. So what we know from imaging is that we can acutely, during the first week following a myocardial infarction, using MRI, imaging of the infarct size, no reflow zone, area at risk, things like that. We can predict pleomorphic VTs during the acute stage and potentially guide the implantation of live vests. But when it comes to guiding ablation and performing CT channel, thickness channel ablation, I would be very cautious. I think it would not necessarily work. And I guess it would be much more complicated to ablate these walls, which would be 8 millimeter thick, or
But even
thinning takes time to happen. This is why probably VT takes time to happen, monomorphic.
But even if you had like the wall thinning in place after a few years, right?
Yeah.
I think we need to understand what kind of channels can support VT, because you have lots of channels in many people there, and you need a special structure, a special combination, a special thinning combination of channels for VT to sustain. And I think it would be really hard to justify a prophylactic VT ablation before we get to the point that we can actually understand what anatomy is required for VT to sustain. I think we're a little bit far from that point yet. But I love the idea of risk stratifying with your induction, because, we are so bad in risk stratifying sudden death in cardiology that could be the new way to see the problem, right?
Mm-hmm.
On that, I have a question for Hubert. Do you think the new imaging modalities will help to better identify the structure of this isthmus, and also smaller circuit with faster VT? Do you think what is coming will help to get better information on the substrate, the characteristics of the substrate, and the spatial resolution, or enough at least?
So there are different answers to that. First, I'm sure that the more we improve imaging, the more we will show details in the scar, and potentially we will find channels everywhere. Like, every infarct has lavas, and they are not, all showing VTs. And so to answer your question, we would need to perform prospective or to follow prospective cohorts. And so we're doing that. We have a project where we're learning also from retrospective data to discriminate between post-infarction that does VT and post-infarction that does not VT based on wall thickness maps. And now then what we can do is we can use generative AI to spot where the risk was identified within the image. So for now, it's a bit rough. So we have big spots. It's not showing channels, but maybe one day we will be able to see these. But I don't expect that imaging only will answer the question. I think some kind of electrophysiological input would be interesting, and I'm looking forward to seeing what AI can do on sinus rhythm EKGs, because combining this with the substrate may be interesting.
I believe we have time for one last question from the audience. Pierre, maybe you can help put that out to our panelists as well.
Yeah, absolutely. So Luis Dos Santos is asking if you have any thoughts on how we could better understand the metabolic environment of scar-related VTs. Any idea? Maybe Hubert with some comments on the FDG or this kind of imaging modality.
Yeah, well, it's not metabolic, but denervation. Yeah, but the metabolic activity. What I understand is that this question points towards imaging scars with PET to better stratify the risk. For sure, with PET, you only have very large pixels. So it's a very sensitive, ultra-sensitive technique, but the pixels are the thickness of the myocardium, you know? So what you will end up imaging is never going to be channels. It can be modification of the substrate that can come and go and that can be modified with drugs. Why not? But I don't see that as a technique that could identify targets, because otherwise these would be huge targets. And this is inherent to the PET technology. It's because of the positron emission has to travel within the tissue before emitting photons. So we cannot progress a lot on spatial resolution with these techniques.
So there is no such improvement as photon counting detectors to be applied here.
Well, you can combine, so that's what's done with PET. You can combine PET with another imaging, but the metabolic information that you would get from PET would have roughly a 4 millimeter spatial resolution, which is the thickness of the myocardium in these diseased areas.
Okay. Thank you.
Well, any more concluding thoughts from our presenters or panelists before we wrap it up? We are at the top.
Congratulations, Fred.
Thank you.
Excellent.
Yeah.
Great work, guys.
Thank you, everyone.
Well, thank you to our presenters and panelists. It was wonderful speaking with you all today and for you sharing your experience with the inHeart solution. And to all of our attendees, we thank you for joining us and for the questions that you submitted. Please reach out if you have further questions to sales@inheartmedical.com. And to watch videos from the series, they are stored on the inHeart website. So please visit inheartmedical.com to see our previous webinars, which also have a robust dialogue and discussion. Thank you, everyone. We wish you a great day, and we look forward to having another webinar in the near future.
Thank you very much. Bye, everyone.
Bye.
Thank you.